Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John. Hi, Zara. It's been a long time.
Yes, we have both taken some time off, some well-deserved time off, personal reasons on my end. John, it is great to see you and be back in our virtual studio again. And you went to ASCO, which I missed, but I am very excited to learn more about what you heard and also the people that you met at ASCO. And I think one of those people is in our virtual studio today. So I'm going to kick it off to you to introduce her.
Kriti and I met at her poster, which I thought was an amazing poster because it's touching on a subject that a lot of doctors and patients do not talk about, and especially it covers an area that one of our guest speakers has already talked about, which is pancreatic cancer. But from Kriti's point of view, is that it's really about the palliative side of pancreatic cancer and the impact that early versus late palliative care can actually play out on patients. So, Kriti, we would really love you to introduce yourself and also talk about yourself and what you're doing, because Kriti's actually in the fellowship program and is learning a lot. So we had a ball at the poster. So thank you very much for all the discussion, Kriti. It was really great.
Thank you so much for such a warm introduction. And I'm really grateful that we met at ASCO that way. And thanks for talking about my poster and having that discussion. About me, my name is Kriti Dhamija. I'm not in the fellowship yet. I'm a second year medicine resident. So I'm still doing my medicine residency. I'm at Allegheny Health Network in Pittsburgh. But from the very starting of my residency, I knew that I wanted to pursue fellowship in hematology and oncology. So I have been working very closely with our oncology attendings at our hospital. I think for the most part, I'm interested in gastrointestinal malignancies. And considering that we've made abundant progress in quite a few malignancies now, I mean, like it's never abundant, but it's still good progress. Like we have made an increase in the survival rates of so many cancers. I think pancreatic cancer is still something which needs more resources and more research. So I think I am more attracted towards pancreatic cancer than others, but I'm still at a very early stage in the career. So we'll see how it goes.
You're dynamic and you're working really, really hard and just come off night duty. Listeners, obviously, we have a really good introduction by Dr. Philip talking about pancreatic cancer and the newly diagnosed and the treatment of pancreatic cancer. This is a very deadly disease and these patients warrant a lot of care. Kriti, talking about palliative medicine, what is it? Because it's not a subject that's talked a lot about from either doctors or patients.
Yeah. So palliative medicine, the main principle of palliative medicine is to reduce or to prevent the suffering that a patient has. And the aim is to improve the quality of life of the patient. We do involve palliative medicine in a lot of topics, but I think mostly we see it getting involved when a patient is facing a terminal
Right.
illness, is at the, which we say that is at like end of life care. But this is what was the initial meaning of palliative medicine. And I think in today's world, the meaning of palliative medicine is changing and it's just not limited to terminal stage of your life, but it can be at the starting of your diagnosis also. And I think its role is really important because cancer definitely is something that takes a toll on the life of a patient.
So, how would you then say that the topic of palliative medicine get introduced? Because I would agree with you, waiting until end of life may be just too far down the line. So maybe step one would be, how does one introduce that topic a lot earlier? like upstream.
Yeah, so I agree. We initially were using palliative medicine only when we were having like goals of care discussion, which means that when we're at a point in a patient's course of illness, when we ask this question that do we need to do more treatment or do we need to have a more comfort approach? This is how the palliative medicine initially began. But now we think that it should be involved early once a disease is diagnosed, especially a disease as deadly as cancer, because there are so many other aspects. Cancer affects and takes its, the cancer emerges in the way of a lot of symptoms, such as the patient would have pain. Pain, I think, would be the biggest reason to involve palliative medicine. Other things would be weakness or fatigue or decreased exercise tolerance. And palliative medicine has so many ways where how we can help patients affected by these symptoms. There are way more symptoms such as like shortness of breath. Some patients develop like bleeding or clotting complications from cancer, loss of appetite. That is such a big thing that comes forward when a person is diagnosed with cancer. And once you have loss of appetite, you get malnutrition, and you need to focus on the energy levels of the patient by focusing on the nutrition levels, and palliative medicine can play a role there as well. Another important thing that is not discussed as much is that cancer is a medical diagnosis, but it also plays a big toll on the patient's mental health. So, the mental health aspect of the cancer also needs to be discussed, and palliative medicine can help with that part as well. So, talking about the emotional distress a patient has or the patient's family has once the cancer is diagnosed is also something that can be helped if we involve palliative medicine in it. So, I think those are the big symptoms where we can take advantage of the situation and introduce palliative medicine into the patient's care.
You bring up a really good point about the patient's mental status, the willingness to either keep trying and living versus giving up. How does that fit into pancreatic cancer? When are those decisions made and whether we're going to keep therapy or versus we're going to manage pain till till the end?
Yeah, that's a really interesting question, and the most important question we're trying to bring up in all the patient visits so that the patients and the doctors are comfortable talking about the topic of palliative medicine. I think I can approach this question in two ways. The first question I would answer is what's the most appropriate time to get palliative medicine involved in the patient's care, especially pancreatic cancer. So I think now, as soon as a patient is diagnosed, as soon as a patient gets this diagnosis of pancreatic cancer, palliative medicine has to be involved at the time of diagnosis. So I think these days, as soon as a patient gets diagnosed with pancreatic cancer, we need to involve palliative medicine right away because it's not only limited, as we mentioned earlier, it's not only limited to discussing about treatment, but it's also playing a role in the symptom management of the patient because the cancer will present with its own symptoms. Then we will institute therapy for the cancer in ways like chemotherapy, immunotherapy, or no, you're fine. I can repeat that last part. So I think the first question to answer that, I would say that as soon as a patient is diagnosed with pancreatic cancer, the patient deserves palliative medicine to be involved right away because the cancer itself would present with such disturbing symptoms medically and emotionally. And once we institute therapy in any form, such as chemotherapy or radiotherapy or immunotherapy or even something like a surgery, the patient would have toxicities related to the therapy. So, side effects coming from those chemotherapeutic drugs. And those side effects would also manifest in the same way like the cancer's symptoms manifest. Because we always see that patients on chemotherapy are very fatigued, they don't have as much energy, they're emotionally disturbed, their sleep is disturbed, and their appetite is disturbed. So, all these symptoms also need to be managed by palliative medicine. So, that's what I would say, that palliative medicine needs to be involved very early in the process of managing pancreatic cancer. And I think you also asked the question about when we ask if we're going to continue with more therapy or we're going to take a comfort approach. I think that is a question that is more driven by the provider. Before we institute chemotherapy, we do like to determine the performance status of a patient. We call it ECOG status, medical terms, but it means how strong a patient is in order to get the chemotherapy. If the patient is already very weak, then the chemotherapy is just going to pose more risks and deteriorate the quality of life of the patient so much that it's not worth it at the point. So we do ask this question to ourselves and let the patient and the patient's families or caregivers know as well that this is what we think, like your performance status is good enough or it's very bad to tolerate more therapy and we might need to stop here, like this might be the end point. And always, I think cancer is a continued partnership between the doctor and the patient, and all the decisions are taken by both of them. But definitely, this is something that the provider needs to determine at each visit or before administering each cycle of therapy, depending on the intensity of how toxic a chemotherapy can be, and as we discussed, depending on the strength or the abilities of a patient to take care of their own activities or how dependent they are on other people.
The question I had was, does it matter what stage a patient is in? So you basically said as soon as the patient is diagnosed with pancreatic cancer, for example, because that's the topic that we're discussing right now. So regardless if a patient is stage 4 or if they're early stage, would you say, irrespective of staging, the discussion around palliation should come in early?
Yeah, I think this is an excellent question because this is a question that all of the providers have been asking over the past few years, and things have been changing based on this question. So, to answer your question, initially, the doctors used to think that if a cancer is very spread out or very metastatic, or what we call as stage 4 cancer, that's when palliative medicine needs to be involved. But nowadays, there's a shifting focus from which is going away from the stage of cancer. So now we say that doesn't matter what stage a patient is diagnosed with, all the pancreatic cancer patients deserve to have a palliative medicine referral early in the course of the disease. And I think we can trace this question back to how palliative medicine has evolved over the past few years because stage 4 disease is more likely to be more debilitating for the patient. And, initially everyone was thinking palliative medicine is involved when the patient is near the death point of their
Yeah.
life. So that's why initially it was probably just limited to stage 4 disease. But now that we are recognizing how it's so helpful for patients in so many more terms than the symptom management, so now we're thinking that all patients should be getting a palliative medicine referral.
So what you're saying is that, Zara and I talk a lot about multidisciplinary teams, and all the major hospitals have multidisciplinary teams. Palliative care has not been part of the multidisciplinary team in the past, and now it's moving in. And obviously, we're going to be talking about your retrospective analysis coming up and the data that you're showing. But is that the case?
That's the right conclusion you drew. We always have these multidisciplinary team meetings or cancer boards for all these patients.
Yeah.
All these multidisciplinary team meetings nowadays, maybe not before, but nowadays it definitely involves palliative medicine. In our hospital, the cancer center is like a separate area of the hospital. And there is a specially designated palliative medicine doctor who works only for the cancer clinic. There's a specific palliative medicine doctor who works only for the neuro, like the brain cancer clinic. So I think now we're recognizing their importance and their involvement in cancer more. And all these multidisciplinary teams now involve one doctor from the palliative care, a nurse from the palliative care, and sometimes people such as nurse navigators also. But definitely, I think coming back to pancreatic cancer, there are so many ways that palliative medicine helps, particularly pancreatic cancer, that multidisciplinary teams become really important. For example, the pancreatic cancer, as I think Dr. Philip mentioned this in their podcast as well, how pancreatic cancer can cause jaundice. And that's one of the main presenting symptoms because it blocks the drainage out of the liver. So jaundice is one thing. And because of this blockage, we need to involve other people, like doctors from other specialities in the care team of a pancreatic cancer patient, also, such as the GI doctors or the gastric surgeons who would help relieve that obstruction. And then there are other people, such as radiation oncologists. And the radiation oncologists are also so important because they not only help with giving therapeutic radiation, like radiation, which is a part of cancer treatment to the patient, but sometimes even for palliation of symptoms, like for reducing just the symptom burden that a patient has, we use radiation. So, radiation oncologists sometimes act as palliative medicine doctors, like in vague terms as well. So, all these doctors need to come together, get a plan, determine the appropriate medications and dosages of medications, and assess the toxicity of the medications, and then play it together.
Before we ask you to dive into your specific data that you presented at ASCO, can I ask this one question just before that?
Yeah, sure.
Resources are a big component, right? So, what you're talking about requires additional resources to be provided for by the cancer institution or by the actual hospital institution. We in the Western world are very lucky that, we have a little bit more access to some of those resources. Our podcast is global. So, my question to you would be what happens in those countries where they aren't as well, like the infrastructure is not as well set up, but yet we've highlighted the importance of palliative medicine. So, how does one balance that importance of palliative medicine with lack of resources? Is there a way to, maybe you haven't discovered this yet, is there a way to integrate the two?
Yeah, I would think my study talks about this thing, resource utilization as well. But before we go into that, I think I can answer this because by incorporating palliative medicine into the care of a patient, I think overall we can reduce the healthcare costs. And we can go more into this when we talk about the study. But I think that's one way the resource limited areas can think about it and try incorporating palliative medicine doctors more into the care of the patient. And I'm definitely very interested to know how this works. And I think it's not so navigating palliative medicine, of course, it's a specialty of its own, and people who are the experts in the field should be doing it. But as I was going through the guidelines, NCCN, which is the website that we follow in the US for all the cancer care, it has a separate guideline section for supportive care, and that is the same as palliative care. So it mentions separate guidelines for managing the pain of a patient, managing nausea of a patient, or several other things like cachexia, like loss of appetite, or just malnutrition that a patient has. So I think those resources, online resources, can be used to come to a conclusion of how you're going to use palliative medicine until you have an expert of the field taking part. And once you have those, it becomes easier for them. Like it's their jam to do it. But I do think that incorporating them would cut the overall healthcare costs that a system would have.
Okay, excellent. Thank you.
In that later stage of life, you've talked about chemotherapy, but now on the marketplace, we've got a lot of targeted therapy. And I'm just wondering, is the targeted therapy beneficial? Is it less toxic in its own right versus chemo? Do the patients, because it's not broken out in your poster that way, is there a difference in palliative approach, targeted versus chemo?
Great question, John.
Yeah, that's a wonderful question. And I would try my best to answer it, but I might not be able to get there. But
Got an MD after your name, so that puts you in the right
There,
place.
he's putting you on the spot, Dan. Well done, John.
it gives me something to explore more. So that is good.
It's
Uh,
another publication.
yeah, maybe another one.
Yeah.
I think that So, since we say the basic principle about chemotherapy is that it's acting against all the growing cells in the body, and that's why it's way more toxic. And now there are emerging targeted therapies, and I think there are quite a few for pancreatic cancer, which have shown good results as well. But I would suppose that targeted therapies are targeting specific cells and specific mutated cells, so their toxicity would be lesser. But either way, I think the patient is still having the diagnosis of cancer and the symptoms arising from the pancreatic cancer. So the involvement of palliative medicine is still not questionable. It still is necessary, irrespective of that part. But I would look more into it.
Good on you, Kriti. Let's talk about your poster. Congratulations, because it's highlighted an unmet need. So you should be talking about young doctors listening to this, how it motivated you into making the decisions that you made.
Yeah, I think it's really inspiring the way it turned out. And I'm really glad with the results that we've had. So I can talk about how we came across this idea. So I had this, as a first year medicine resident, I attended this pancreatic cancer symposium, which was actually organized by my mentor who works in pancreatic cancer, Dr. Monga. And one of the talks in that symposium was about the palliative care involvement. I went back and studied more about it, and then I came across this one study which showed it's a very famous study in the people who are famous in like pancreatic, famous in like palliative care department, and that study was showing how early involvement of palliative medicine in lung cancer, non-small cell lung cancer specifically, showed really good results. And they were just trying to see results in terms of the quality of life a patient has, or the mood symptoms that a patient has, or depression and anxiety and things like that. But accidentally, they also found, I don't know if it was accidental or like intentional, but they also found that the survival rates of people with non small cell lung cancer were better if palliative medicine was involved early. So we wanted to do the same thing for pancreatic cancer, and that's how this idea came up. So I started talking to my pancreatic cancer mentor and my palliative care attending as well. And we were kind of skeptical considering how aggressive the malignancy is when we talk about pancreatic cancer as compared to other cancers. But still, we had certain ideas and we tweaked our ideas a little bit to come across the project. And what we did in the project was we took 9 years of data from 2015 to 2024 at the Allegheny Health Network in Pittsburgh, and we looked at all the pancreatic cancer patients during these 9 years. And Zara, just to include your question into it, we do have data about the stage of pancreatic patient, but we included all the patients because all the patients should be getting a diagnosis, should be getting a referral for palliative medicine. And then for all these pancreatic cancer patients, we looked at the patients who had palliative care referral as an outpatient referral and were involved with the palliative care doctors. And out of those patients, we divided them into two separate groups. One of the groups had an early involvement of palliative medicine, and the other one had late involvement of palliative medicine. And the way we defined early versus late involvement was we looked at the time from the diagnosis of pancreatic cancer till the time the patient got involved with palliative medicine. If that time was less than 3 months, we considered it to be early involvement, and more than or equal to 3 months, we put it into the late involvement of palliative care. So we called them early and late palliative care referral cohorts. And then we compared these two cohorts and several other variables. And I can talk more about it in terms of, as you just asked us about the resource utilization. So the main objective of our study was to find the healthcare utilization between the two groups and compare that. And to look at the healthcare utilization, we looked at several other points. One of them was the number of emergency department visits a patient has. So we compared the number of visits in the two cohorts that we had, the early cohort and the late cohort. Similarly, we compared, so as I mentioned, like the number one complaint that a patient with cancer or pancreatic cancer in particular would have would be pain. So we compared the number of ED visits which were specifically due to pain in the two cohorts. And we compared other things like number of hospital admissions, like inpatient admissions, number of ICU admissions that a patient has. And with our statistical models, we found that all these healthcare utilization metrics, they were lesser in the early cohort as compared to the late cohort. Meaning, so to simply put it together, if a patient gets involved with palliative medicine early in the course of the pancreatic cancer, which was less than 3 months from diagnosis, the chances of them ending up in the ED for any reason or for pain, the chances of them getting admitted to the hospital or getting admitted to the ICU were way lesser compared to them getting involved with palliative department later in the course. So that's why we were promoting early palliative care involvement. So that because as if we think more about it, if a patient is repeatedly coming to the ER, that is causing so much burden on the patient, on the caregivers, on the family, financially, emotionally, and even physically. And it's such a torment to be in the hospital when you could have prevented that visit. If you involve the palliative medicine department early, you can prevent all of this burden on the patient.
And the other question I had, sorry, what were the numbers that were per cohort that we're looking at? That you're looking at
So you mean the number of visits or like the number of patients that we
number
have?
of patients.
172 in the PCR arm in the early and 137 in the PCR in the lates.
Yeah. So I agree. These were the exact numbers that John memorized.
I've got the poster open in front of me.
So, yeah, as you mentioned, there were more patients in the early cohort, which was a good thing. And it represents good health, good palliative medicine involvement, at least in our center. To talk about the number of visits, we found that the median number of visits in the early cohort, and we're talking about the ED visits, was 2 in the early cohort and 3 in the late cohort. And this difference was statistically significant. Similarly, if we talk about hospital admissions, there were just like median number 2 visits in the early cohort and 4 visits in the late cohort. These are just examples, but all of the visits were lesser in the early cohort as compared to the late cohort.
You've got the poster published. What happens now? What's your next step with this information? Publication, etc.?
Okay. I think we got the results that we were looking for, and this is what we expected from our current study. But we are trying to expand this project. Currently, I'm working with the people in the insurance department of our hospital, and they are trying to give me numbers which can actually give me like bills of the patients, and we can compare the healthcare utilization costs in terms of actual figures between the early and the late cohort and see how much money went into taking care of these patients and how much money we could basically save if we could involve the palliative care department earlier in the course of the cancer diagnosis of the patient. So that's going to be one thing. The second thing is that we are working to try to compare the survival between the two cohorts, the early and the late cohort, because the lung cancer study did show that if we involve palliative medicine early in the course of the cancer, the survival was better for lung cancer patients. But this is something which is very touchy of a topic, I would say, because it's pancreatic cancer and patients do not live very long for us to
Mm.
make those conclusions. So it's so aggressive. So we will see what the results show, but that is our next step to compare the survival between the two groups. And once we have all these results, definitely the ultimate target is to publish this study, because the thing is that there are not many studies on pancreatic cancer, and especially on palliative medicine in pancreatic cancer, which is so narrow of a topic. And there are so many misbeliefs about palliative medicine amongst the providers and more so maybe amongst the patients as well, that this topic is not being talked about as much. So we definitely want to spread the word and get the study published as soon as possible. But yeah, these are our main steps which we're thinking about to get done as soon.
Sounds great. And obviously, you've got some more research to do with looking at the differences of the new targeted therapies versus chemo in the outcomes of palliative care. And how that's actually impacting survival as well. That would be very, very interesting. Being involved in targeted therapy the last 18 years, it's going to be great to see if it's really playing out in this field of palliation. Pat, how did this whole project impact you, and how are you making the decision as to where you want to be when you look at your fellowship?
Yeah, I think there's this joke going around about oncologists that I'm coming across now, now that I want to apply to it. Like my friends would say this to me that the oncologists don't really like palliative medicine. But I think this is my main thing. I want to change this belief that other doctors have about oncologists because quality of life of the patient is very important, and I think that's what matters. Like that's what we're working for. We're not working just to increase the number of years a patient lives, but the number of quality years that a patient has to spend. So that's going to be my main target once I get into fellowship, to incorporate more of palliation also, along with all these newly emerging therapies like targeted therapies. But yeah, that's my main idea that drives me right now. But I'm gonna apply for fellowship and see where I end up, and see what what kind of resources I have to do more research, and then take it forward from there. But I think going to places such as these conferences, you come across so many people like we met, and today we're here. I would have never imagined this is somewhere I'm gonna end up. I met some other palliative medicine doctors. I met other GI oncologists who are particularly doing research in pancreatic cancer. So the ideas that I mentioned that are our next steps, we're trying to collaborate with other people who are the experts in the field, so that they can give their insight and support to us as well, and then we can carry this project forward or even come up with new ideas. But that's one thing which is currently on my head.
So, if you were talking to new students, new doctors that are interning, why don't you give us your insights from the experiences that you've had, the good ones, the bad ones, how you make decisions, how you actually ended up on this project,
Mhm.
just for their point of view?
I agree. I think this is so important to me because I just put myself into it, and then I navigated through it and found my way. But definitely, I would love to share my experience if someone can learn from it. So I think the way the ideas come for doing these research projects is to have more information. So, how I started was that I just had a few interesting cases that I published as case reports and made posters out of it, which got selected into some conferences. And once you go to a conference, there are so many interesting talks happening. As I mentioned, when I went to this pancreatic
Mm.
cancer symposium, there was this palliative medicine talk happening. And once people are discussing their own research and how they had their ideas, you come up with your own questions like, why did you do this in one particular way and not the other one? So, what I used to do was that I would, all the ideas that would come to my head, I would like jot them down on my notes. And once the conference was over, I would go to my own mentors and discuss all my ideas. And like in the interim period after the conference and before I went to the mentor, I would do my own literature search that my question should be a valid question and an informed question. I should know what has already been published regarding that field. For example, when I did this palliative medicine in pancreatic cancer, I knew about palliative medicine in lung cancer and how that study played out. So I could do the same for pancreatic cancer, and I could present that topic to my mentor. And that's how she was interested. So I think you just need to put in your homework before you present an idea of yours. And I think if you have good mentors who are there for you, who can support you, can tell you what you're doing right and wrong, you can carry it forward. And I also think the main thing is to ask for help, because I did not know how to do the statistics. So I had to ask for help for that from a particular statistician that our research department has. I wanted to do this project on a larger scale than just my hospital. So I got involved with, like, our hospital is funded by Highmark Insurance. So I spoke to the Highmark Insurance people, and they gave me data of like all the hospitals which are in this Allegheny Health Network. So it was a multi center study kind of a thing. It was like the center is basically one, but a multi hospital study, which maybe I should use.
That's a great piece of advice to give to other doctors like yourself is that most of the hospitals are in their own huge network. That's good information.
And I think once you keep on presenting these things at conferences, there happens collaboration of ideas. And I think ideas grow stronger if there are more minds involved into it. One setback I think that we should be aware of and should not get demotivated is that sometimes the study doesn't play out the way you want it to. Like, I wanted to show improved survival with early palliative care in pancreatic cancer also, but I need to understand that it's not possible because it's pancreatic cancer. But still, I'm showing so many other things which are important, like reduced healthcare utilization costs and better quality of life. So that was one thing. The day I got those results, I was a little sad, but I spoke to my mentors, and they were like, "No, you did what was supposed to do, and this is even negative studies are important studies. We need to show that out too." So that is another thing that we should keep in mind.
Been involved with plenty of randomized phase 3 studies that haven't made it, and that's a huge output from both the doctors, the patients, and the pharmaceutical industries. Now, if you don't do the research, you won't know the answer.
Right.
So I've got one last question for you, Kriti. Why is it that doctors shy away from discussing palliative care? And
I think that's very important to address. And I would say there are so many aspects to it. There are so many reasons why palliative medicine is not a topic which is discussed as much as it should be. I think over the past few years, when you use the term palliative medicine in front of a patient, the doctor is scared and the patient is scared because everyone associates the term palliative medicine with end of life. And they have an idea that, oh, we are going to die. And doctors, being doctors, they're being viewed as people who are there to prolong life and not to shorten life. But palliative, if you say palliative, they're like, oh, the patient would ask you, like, oh, am I going to die? And that is something that no one wants, like, people shy away from addressing, I would say.
had a
Some
negative connotation when we discussed palliative.
Right. And some people think that it shortens the life, and it also I can see a patient thinking that once my doctor brings the term palliative medicine into play, the doctor is not playing the role of a doctor, and they are not giving me the treatment that I should be getting, but are rather trying to focus on my comfort. And I think that needs to be changed also because, as we were mentioning, that palliative medicine is not just for the time when the patient approaches the end of life, but also for managing all other symptoms. Like, we can continue all the chemotherapy, all the radiotherapy or targeted therapy that we have, but we also need to take care of all these other symptoms that a patient is having, like pain or jaundice or fatigue. And we need to address those so that the patient's quality of life is better. And once the quality of life is better, the patient is themselves more motivated and more involved in their care, and they can get the further pending cycles of their chemotherapy or targeted therapy. But to get all those cycles, you have to be a strong, like, your body has to be strong enough. And I think, I don't know if there's much research about it, but I think mentally also you have to be in a place where you're very sound and you are up for it, like you're motivated to get that therapy. And when we
Yeah,
involve medicine, we do discuss things such as depression, such as anxiety, because cancer is definitely the worst news someone would receive, and that would definitely deteriorate your mood and your stress and your anxiety levels. So that needs to be maintained also. When we talk about palliative medicine, we do involve psychiatrists or psychologists or support groups or the spiritual help that we can give to the patients. I think there are a lot of myths associated with palliative medicine, but we can also be working as clinicians and as patients or support givers or caregivers to debunk all of these myths and get the palliative medicine involved in the care.
how important is the family? I see, e- even from my own experience, we see confrontation, we see anxiety, we see difference of opinions. How do you negotiate through that process?
I think family or friends or whoever you see as a trustworthy figure, that's very important to have for a patient at the time when they get diagnosed with cancer, because they're going to be so weak. Someone has to be there for them to take care of them, to take care of their activities of daily living, such as bathing or just like cleaning themselves or the apartment and providing for them. And also important to bring them to their doctor visits. There's a very big role that the family plays physically. Having said that, I also think mentally, if you have people around you who can talk to you and calm you and provide emotional support to you, that's very important. At the very first visit, when we see patients as oncologists, we definitely ask the patients about what kind of support do they have. If a patient is by themselves, it's very difficult for them to navigate all of these things by themselves. Another thing I would say, since we're talking about family, I think when we're treating a patient who has cancer, it's not just the patient that we focus on, but we also focus on the patient's family. I am very lucky to have such a nice mentor, as I mentioned, Dr. Monga. I have been working with her in her clinic, and I have seen she's close to her patients, but she's also close to her patients' partners or whoever, mother or whoever comes with them to their visits. And she always asks the patient's caregiver also, like, how are they doing? Because their physical and mental health is also important. If your family member gets diagnosed with cancer, even even your own health can be affected by that. And we need to acknowledge that part as well. And I think palliative medicine does an excellent job at all of these things, because each palliative visit not only involves the patient, but their caregivers as well. And they would always ask the opinions that all of the people involved in that discussion would have. So the opinions of the family or the caregivers would be equally important, maybe equally. I mean, like the patient's opinion is the most important one, and they take all the decisions. But we do ask for opinions from all the people present in the room, and we provide support not only to the patients but also to the caregivers, because we need to take care of them so that they can take care of the patient as well. So all these support group, there are so many resources available how we can help them once they get involved with the palliative medicine department. Some places also offer spiritual support if if that's something a patient or the family would be up for. That is another way. And also, I think an oncologist by themselves can only do so much. There is limited time. And we would want to do everything for the patient, but you have to recognize your own limitations also. And sometimes you need to involve other departments like palliative medicine so that they can take over what you've left and discuss these things with the patient and the family. That is definitely something which will be helpful not only for the patients but also for the doctors, and would be the best people to mediate all these discussions.
Kriti, we're approaching our time. If you had to say three things to everybody that's listening to you now and summarize what you discussed, what would you say about palliative care generally, and then more specifically about palliative care referral in pancreatic cancer?
I would start by saying that we need to dissociate from the idea of palliative medicine being involved for end of life, and rather think of palliative medicine as something which was focused for the quality of life of a patient. Second thing I would say is that cancer is a very tormenting diagnosis, and cancer by itself and the treatment that a patient would opt or a doctor would provide will also cause so much distress physically and emotionally. And involvement of palliative medicine would help navigate all navigate this journey and make all these symptoms easier for the patient and the family of the patient. So definitely palliative medicine is, if anything, it's only going to help. Talking about pancreatic cancer in particular, I think all cancers, but especially pancreatic cancer, deserve the involvement of palliative medicine as early in the course of a patient's diagnosis as possible, so that we can make the patient physically and emotionally stronger, and they can take onus of their care more. And that is possible only if their symptoms are well managed. And this would reduce not only the burden on the patient and the family, but this would also reduce the burden on healthcare, because the healthcare utilization metrics, as have been shown by several studies, including mine, is that they're lesser if you involve palliative medicine.
Last question. As an intern, you've spoken several times in this episode about your mentor. So one of the things interns have to do is they have to manage up as well as down. How would you guide a new intern into managing up? Especially today, you're blessed, you've got a great mentor. Tomorrow, it might not be the case. So, how would you manage mentors in the medical system?
I think that's really important as a question that I should be asking myself. And
That's why you got me.
yeah, that's giving me real insight today. But I think when you have genuine interest and your interest aligns with the interests of your mentor, that can go a long way. Second thing I think is that when you present your work, when you're open about your work, you're proud about it, and you can talk about what you think and what your ideas are, that attracts similarly focused minds. And conferences, I think, are a great opportunity to reach out to other people for more collaboration and for continued work. And that's what I have been doing. And another thing is that a great mentor would never leave you alone. My mentor has been so helpful that she has been connecting me with other mentors also. I think that's a really positive sign about a good mentor, that they would want the progress of their mentee. They would want them to see up and up. So she has been connecting me with other people who have similar interests like mine and are more involved in research so that they can guide me further. But yeah. And talking about managing people who are coming after you, I think what I did was that I carried this idea forward by myself initially, because I didn't know where it was going and how it was going to turn out. But once I had confidence that we are reaching the end, I started involving my juniors in the residency program so that they could have like a superficial idea of how to do things. And and once I go further away, they know how to do it, and they can then carry forward things from there, and they can start their own things. So I think it's like a continuous process. You gain from someone and you give to someone.
Fantastic. What a way to finish discussion on palliative care and managing patients. Pretty. So, on behalf of MedInsights Unleashed and all our listeners out there, we can't thank you enough for all the time that you've given us today. But not only that, it's the time you're giving to patients and to their families. We want to say all the best with your future and your career.
Mhm. Thank you so much. It was a wonderful experience. I think the questions were excellent and very insightful. And I hope we can spread the word about this and everyone out there can get inspired to in their medical field and their research work and carry it forward from there.
Well, it goes out globally, so we're going to do our bit to get the message out there for you, Kriti.
Thank you so much for the opportunity.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.